So this presentation is again something that we have been working very closely in the last 2-3 years. As all of you are, I'm pretty sure all of you must be doing cataract surgeries, phacos routinely in your practice. Now I think as the generation is changing and the demands of patients are going to change, slowly cataract is becoming a refractive procedure. It is no longer just a sight restoring procedure, but the patients also expect very good refractive outcomes out of it. So in the next few slides, I'll try to keep it simple so that we can have more discussion on it. Yeah, so once the scope of this talk, I'll briefly tell about the background of this. And the most important part of refractive cataract surgery is patient engagement. So how do you engage with patients and convince them for a refractive cataract surgery, or when to take them up? What are the important preoperative measures and intraoperative measures to have better outcomes? We'll discuss under the following headings. So I think once I use the word refractive cataract surgery, in everybody's mind, you'll start thinking about this fancy equipment, whether it is femtosecond cataract, intraoperative aberrometry, advanced optical biometers, topographers, imaging systems, or intraoperative imaging guiding systems. But the fact is, to do a refractive cataract surgery, you don't actually need any of this. This is only a myth that refractive cataract surgery can be done only with expensive high-end technology. We can do that with whatever regular equipment that is there in your OPD and OT. So I'll tell about those things in the coming slides. So before going to that, what you need are two main ingredients to do a perfect refractive cataract surgery. One is you should have a growth mindset. You should not be satisfied with what we are doing, because as I've told you, the generation that is going to come up next for surgeries will be more demanding. We as surgeons have to be prepared to meet their demands. We should be prepared to accept their challenges and also take it as an opportunity to improve upon ourselves. Once you have this right kind of mindset, the next important thing is you should prepare your team. Only as a surgeon, if you're prepared to do cataract surgery, it is not going to happen. Refractive cataract surgery is like a thing that should be accepted by your team first before the patients. Right from your receptionist, vision technician, counselor, OT staff, everybody should be convinced that refractive cataract surgery, someday or the other, we have to do it. So let us start taking small steps from today so that we reach that goal at some point of time. So refractive cataract surgery should not be equated to premium cataract surgery. See, premium cataract surgery is different. You do a femtosecond laser, you do a femtosecond assisted cataract surgery, you do a 3D cataract surgery, you still implant a monofocal IOL. That is a premium cataract surgery. It is not refractive cataract surgery. So the difference between these two, I'll try to tell in the coming slides. So most important thing, as I've told you, the difference between these two is refractive cataract surgery, as all of us know, our natural lens has two important functions. One is for the focusing, two is for the clarity. We all have very good focusing capacity till our 40s. And once we reach our 40, we lose that capacity and we become presbyopic. Later in late 50s or 60s, you get cataract when you lose the clarity. But what happens is when we give an option for the patient to replace this lens, most of us are struck only with giving them an option of replacing the clarity, and we don't discuss at all about the focusing part. So once we get this dialogue into the patient's mind, he will also start to think. I'm not telling that we have to push each and every case for refractive surgery, but I think with the evolving generation and the evolving needs, you all of us know how many of us are dependent upon our mobile phones now, including our parents or grandparents. Now they are more used to reading or indoor activities, and especially during this lockdown, they're more dependent on digital screens. And in this scenario, their demands for near or intermediate vision may go up. So you have to take that into consideration. So in patient engagement, the important thing is always place education material in your waiting hall so that the patient will already read through what is it, whatever I have told you now regarding the natural lens and its functions, how there is an opportunity to get both the functions back with a cataract surgery. This should be displayed prominently along with the reading material so that he'll get an idea even before he comes to see you in your consultation room. So once that happens, then you have to be careful in two important things. So you have to ask the patient, what is his regular working distance? What are his needs? And is he comfortable with using glasses? If the patient is comfortable with using glasses, we need not ask the patient to go in for a refractive cataract surgery. Still, there are patients that you have to be wary. That is the personality type who are perfectionist. Being a perfectionist is nothing bad at all. They will excel in all the fields that they take. But when it comes to refractive cataract surgery, they also expect perfectionism, which is not possible despite of the best technology we have. So there is, you may feel delicate to tell them that you are a perfectionist, I can't give you a multifocal option. You have to tell them that you are a perfectionist, but that perfectionism is good for other aspects of life. But once you are here, you can't expect things to be perfect, because what I'm telling is once you're straightforward in this communication, if they're not interested, well and good. If they're still interested, then their expectations will come down and your life will be easy later. And also in patients who do a lot of night driving, we try to avoid this trifocal or multifocal lenses. So as I've told you, try to educate the patient, but never emphasize that you have to go only for this. You educate, leave it to them, and you tell what is best. In my opinion, don't give too many options. Don't fill a paper with 15 to 20 options and confuse the patient. Make it simple. Monofocal, in that monofocal, whether it is a economical thing or the premium thing the patient wants, then go in for a toric place. If the patient has astigmatism, the toric lens should be offered. Then go in for a toric IOL where you can give a affordable one and a costly one. So just keep it 4 or 5 options so that it will be easy for the patient to choose. If you give 15 to 20, he will be confused, and in that confusion, he may not be able to take a right choice. And also, once the patient has agreed for a refractive cataract surgery, you have to tell him that this is not a one-step process like a monofocal or a traditional cataract surgery. It has multiple steps, which we'll explain in the coming slides. Actually, we did a survey for nearly 1,200 patients, in which 85% of them actually, when explained and educated, wanted to get a refractive cataract surgery done. However, it's a different matter that only 8% could opt, because the main constraint was a financial constraint. So they were telling that if finance is not a constraint, everybody was willing. So that is the main limiting factor for refractive cataract surgery that we are seeing right now. And also make sure that, especially if the patient has insurance, whether that insurance will support for the toric, multifocal or EDOF or other lenses that you're planning to place in this patient's eye. Because otherwise he has to bear that expenses out of the pocket. So all these things should be discussed in detail. This is the first and most important step, where you have to give the patient an option, set realistic expectations, and then you have to take the next step. So as I've told you, the most important thing in refractive cataract surgery, like Vance Thompson from USA tells, is 3 months and 3 steps and 6 months. So what are the steps? This is implantation of a refractive IOL is obviously the first step. So implantation of an IOL, that could be a refractive IOL, could be a toric IOL if the patient has astigmatism, or it could be a trifocal or a multifocal or EDOF lens, depending upon the patient's need. Next thing, important thing that you have to make the patient understand is there is something called as the healing blur. Healing blur is nothing but the incisional healing. That is, when you have given the main incisions and side port incisions, because of the healing of these incisions, there can be some form of astigmatism. And also, we all of us know that the effective lens position is not stable. There can be some form of variability in the effective lens position. So taking these two into consideration, there can be immediate post-op, the patient can have good vision. But probably after 3 months, if there is a blur of that vision, that could be caused by this entity called as the healing blur. And the third important thing that you have to tell is, if there are any capsular changes, the patient may require a YAG capsulotomy also. So when you tell them that this is a multi-stepped approach, a refractive cataract surgery is not a one-stop destination, but it is a journey that will take 6 months' time. So once you operate the one eye, you can operate the second eye within 2 weeks or 1 month. And then after you do these 3 steps, some of the patients may not require the second and third steps, but still will take some time to get neuroadaptation to this new optical system. So always tell them to be prepared for 6 months. 90% of the time, most of the patients are happy within the first few weeks to 1 month. But when you prepare them for a longer time, it would be a pleasant surprise for them to have good vision at an earlier thing. Never promise early and then delay it. Always do it other way around. An important thing, especially when you're going for refractive cataract surgery, is never delay the surgery. Let the cataract not become hard or mature, and when the things may get out of your control in phaco. So always try to take up the case when the nucleus is not very hard, so that you can easily finish off your phaco and you can use lesser phaco energy. And always prefer an early surgery for early, and both surgeries within 1 month would be better, because binocularly the adaptation would be better and they'll also be happy. So that is one thing. And for all refractive cataract surgery, tear film optimization is very mandatory. This I'll discuss in detail in the coming slides. So next, coming to the ocular assessment. So you all of us have to ask for the symptoms of dry eye. That lot of questionnaires on dry eye are available in the net. You can download any of them, and the speed questionnaire is very useful. It has only 5 questions and the patient can easily fill in that. You can translate into our local languages. Most important thing in slit lamp examination is we miss out often is the lids part, that I'll explain in detail. That is LLPP, look, lift, pull and push. What these are, I'll show in the next slide. Next, by seeing a simple Lissamine green staining, you can assess for dry eye. When you do a Lissamine green staining and ask the patient to blink twice and then see on the slit lamp, if you are able to see more than 5 corneal spots or more than 9 conjunctival spots, the patient definitely has a dry eye. And also the Lissamine green will also stain the lid margins. So if the lid margin is stained more than 2 millimeters in length or more than 25% staining in breadth, it is a sign of dry eye. So all these cases, you have to treat dry eye aggressively first, because if you don't treat the ocular surface, you will not get the correct IOL power. And without correct IOL power, it is very difficult to do a refractive cataract surgery. Dry eye treatment in these refractive cataract surgery patients has to be more aggressive. It should not be a stepwise fashion like regular dry eye patients. We have to go in and give everything that is available to us, not only artificial tears. If required, we have to start them on steroids, cyclosporin, oral omega-3 fatty acids, and now we have several treatments like the warm compresses, intense pulse light, LipiFlow. So whatever treatments are there, first stabilize the tear film. Only then you take the case for surgery. Usually when they have this kind of problems, you can treat it within 1 month's time and then take the patient for surgery. So as I've told you about the LLPP, so I'm very specifically not going to the advanced techniques here. As I've told you previously also, I'm telling you only to do a Lesamine green staining. That is a very reliable test for dry eye. Now I am telling something that you have to look for in the Edinexa. So always look for lashes, lid position, blink position, tear meniscus, conjunctiva. Lift the upper lid, look at the superior cornea, look for any conjunctival abnormalities, SLKs, pull the lower lid, pull the upper lid and look for laxity and floppiness, and always push to see for whether the mebum is expressing properly, quantity and quality is good, and any of it is there, treat it first and only then take it for surgery. Why I am so specific about ocular surface is because most of the times you see you have done a wonderful surgery, even a regular cataract surgery, forget refractive cataract surgery. The patient will be complaining in the post-operative period about mild irritation, vague complaints. 90% of those complaints are because of the ocular surface disease. This ocular surface disease will be subclinical preoperatively. Your surgery will make it over and the symptoms will be there after the surgery. So whenever you document these subclinical things preoperatively and convince the patient that he already has an existing mild to moderate dry eye that may worsen after cataract surgery, he will be able to accept and also take the treatment for dry eye first and then also use the drops more rigorously after the post-op, because you have to document and show him that there is certain problem, because all they think during cataract surgery is they have put a costly lens and they should get the thing back. But we have to explain to them that lens is only part of the entire optical system and in which ocular surface also plays a very key role for a better quality of vision. So coming to the IOL power calculation, in case of refractive cataract surgery, again, you need not invest in any of the high-end machines. Ultrasonic pachymetry contact, I don't think we are still using it, but if you are using it, please don't use it for refractive cataract surgery. Use the immersion technique with the ultrasonic thing, because optical biometers, if you have, you can use it. The number 5, 1 and 0.5 are nothing. So if you're using a contact ultrasonic your thing for your calculation, the chance of error, suppose it is 5. If you use an immersion, it will come down to 1. And if you are using an optical biometer, it will come down to 0.5. So that is how it works. So if you have access to optical biometer, you can use it, no problem. But don't be afraid that without optical biometer, you cannot do refractive cataract surgery. You can still go ahead with your regular ultrasonic, but use a probe with help of an immersion technique that gives better results. Manual keratometry and auto keratometry are equally good. And the important thing here is, rather than the machines, make sure that these readings are taken by 2 people and then see for any difference. And if you see a difference, repeat it for the 3rd time. And also take into account pre-existing refractive errors. There is a group called as danger group that we call in refractive cataract surgery. That's a myopic patient of -3 diopters. If this patient comes for cataract surgery, you have to try to convince him for refractive cataract surgery. If you just do a monofocal, he's going to lose his reading and he'll be very upset post-operatively because he lost his reading capacity after the surgery. And in the same way, astigmatism patients, you have to tell them that the astigmatism cannot be treated only by a monofocal lens alone. They may require a toric lens that has to be done. Once your readings are there, now we have a very free online calculators. We prefer to use the Barrett's Universal 2. And for short eyes and long eyes, there are correcting factors that you can go for ASCRS or APCRS websites that are again freely available. So this is the Barrett's Universal 2 formula that we routinely use. And in case of refractive cataract surgery, we try to do it with two formulas. We use the Keynes formula also. The Keynes formula is different in a way that it also takes the age and sex of the patient, and artificial intelligence is included in the study. So just need to input these measures and the online calculator will automatically give you the IOL power that has to be implanted. So I think these online calculators have made our job much easier. Once you are able to get the axial length with the methods I have told you, and the refraction, everything, whatever is there, the optional things like lens thickness, white to white, or central corneal thickness, they are optional. If you have instruments to measure them, you can go ahead and put in. But if you don't put in those measures also, you'll still get a good, reliable IOL power calculation. So coming to the incisions. So incisions, there is a lot of debate whether we have to go for 2.2 or 2.8. In refractive cataract surgery, I would say more than the incision, you have to be careful about causing wound stress. If you do a 2.2 and every time you go in, you try to put some pressure, that will cause wound stress that is worse than a 2.8 incision. So if you are comfortable with a 2.8 and your surgically induced astigmatism is not significant, as long as that is there, it should not make much of a difference. So go by your comfort. Don't think that smaller incision is always better. Creating a smaller incision and manipulating it more is more harmful than doing a bigger incision. And it's already known, most of you must be doing that. The length and breadth of the incision, it has to be like a good thing. And it should always be near the limbus. How do you know it's near the limbus? There should be some evident bleeding when you do this incision. Otherwise, if it's too clear corneal, the healing will not be as good. And minimal astigmatism like 0.75 to 1, you can manage with LRIs. Again, for LRIs, you have online calculators and a lot of mobile applications. You put in the K1, K2 values, it will give an exact figure where you have to do this limbal relaxing incisions manually. If you have access to femto, you can do it, but you don't need a femto to do limbal relaxing incisions. And coming to the Rigus, that is the most important part for this multifocal or toric IOLs. Sizing is important. 5 to 5.5 should be there so that the lens will have a good overlap. So how do you know that? There are a lot of markers that you can mark on the cornea and then take that as a guide to do your incision. Most mistake all of us do is taking the iris as a guide for making these incisions. Iris can vary depending upon the pupillary dilatation. Never take the iris as a guide. Always take the markers, corneal markers, and mark it on the cornea so that you can see it as a guide when you're doing the corneal rhexis below in the anterior chamber. Apart from that, centration of the rhexis is important. So always mark the cornea when the patient is in sitting position in the slit lamp. Intraop guiders are not required. And you have to be careful while doing mature cataracts. The technique that we use for mature cataracts is decompression and spiraling technique. That is, we directly go into the puncture the anterior lens capsule and suck out the milky fluid to decompress and reduce the pressure. Once that is there, then you can put a high density visco and slowly start off as a small rhexis and then spiral it out to the size that you want. This is a very safe and proven technique in case of mature cataracts, where the rhexis becomes a very important thing if you want to implant a refractive IOL. And last thing is the IOL implantation. So IOL implantation, again, you may be thinking for refractive thing, you need a intraoperative imaging system or guiding system. I think if your microscope has a beautiful coaxial illumination, that is more than enough to do the centration. So first thing is, all of you know, should place it in the bag. It should be well centered. And you should always have a backup IOL for all these refractive things, because once you have promised that and the lens has damage before going into the eye, you should have a backup for it. And don't hesitate to convert to monofocal, especially when the complications are more. So here I'll try to tell you about the Purkinje images, that is very useful to you. So there are 4 Purkinje images. Purkinje 1 is from the corneal anterior surface, 2 from the corneal posterior surface, 3rd from the anterior lens surface, and 4 from the posterior lens surface. P2 we cannot see, P1, P3 and P4 we can see. So location of P1 is on the anterior lens or on the IOL. P3 is in the vitreous and P4 is on the cornea. So what happens is, orientation, if you see here in C, in image C, you can see that inverted Purkinje image P4 and straight Purkinje image P1. So when you try to see without parallax error, these two are in the same phase and your lens is centered to it. It is 100% sure that your IOL is in the center. This is useful both for trifocal or multifocal IOLs and toric IOLs. So just by looking in a coaxial illuminations, try to locate where this P1 and P4 are and make sure that they are in the same axis. Because P4 is on the cornea, that center is same. So P1 which is there on the IOL, that you have to make sure that it is corresponding to this P1 or P4 image should correspond to each other. So this is a simple technique by which you can do a good centration. I hope these simple things will help you to start your refractive IOL surgery. Thank you. And now we'll take some questions.
Thank you, sir. The house is open for questions.